Thank you very much to everyone for joining us this morning for the second of these conversations on the Side Porch. We've been blessed over the last few months to have learned and been connected with a group of extraordinary people who are really working hard in service to communities around our country, around the world. We wanted to bring these groups together and be able to share some of these conversations with as many as we could. We originally founded SidePorch, this organization that we're running, to do exactly that, to create a space where we pull together people that we care about, that can come together in a curated space to be able to talk about important things in service to our communities. So that's what we're doing here. We're trying to share information. We're open offers for connections of information or connections to resources. Robin Smith, Raman Bastani are here with us. We can connect you to them, but also any of the other groups that we've come in contact with. And also it's important to us to connect this community. So we would encourage everyone to rename yourself in the chat with your name and your affiliation. Unlike a lot of the chat meetings sessions that we've seen, we're keeping the chat open so you can directly chat to each other and get to know each other. We'd also encourage everyone to use that chat to throw questions in. We'll open up for questions from the audience, but if there's things you're interested in, please include it in chat so that we can address it and try and weave it in, or we can get to it after this session as well. SidePorch, since early March, has been pretty involved in COVID response. We started by supporting a diagnostic lab to ramp up their operations and build their sales channels. And since then, we've been working in consulting engagements with counties, cities, municipalities, universities, athletics groups, for-profit, not-for-profit groups. We've been identifying resources across the country and indeed across the world to try and connect the resources to the appropriate areas that they could use their services and skills. And now we're trying to be able to pull these communities together. So logistics today, as we shared, we're recording this and we're going to be putting it up on our website probably within the next day so that we can try and get this out to as many as possible. We are going to be putting up the videos of those who are speaking. The audience isn't going to be up there, but we are going to try and put this out. A few links are going to be put up in chat over time. Andy's going to put them up, links to the other resources we have, to some videos that we have that might be of interest, including a tour of Robin's lab behind him. And then we'll reach out after this to make sure that we can be available to you. Last week, we did one with universities and athletics groups. We found that some of the chat we got a few questions, but not many. But please send stuff into the chat if there's any ways that we can use that in this session. So I'll start in terms of how we're going to run this. I'm going to give a few overall observations that we've seen that apply to many different environments, but particularly to cities, municipalities, counties. Then we're going to invite our two guests here, Raman and Robin, to join us in conversation. I have a few questions that they've seen ahead of time, and then we'll see where the conversation goes, but hopefully the audience gets to play in as well. You know, we're all operating in an environment right now where we have insufficient information, that we don't know what's coming down the pike. And many of our organizations and the individuals running organizations haven't been trained to operate in this type of an adaptive, quickly changing environment. So it offers challenges, but at the same time, there are certain industries, sectors, companies that have to make decisions. Some are able to kick the can down the road and say, we're not going to reopen for a while and we're going to wait for the environment to kind of firm up. But groups like universities, groups like athletics that we talked about last week, but cities and counties, states have to make decisions now and have been making decisions over the last few months. So we're going to be focusing on those kind of groups. These are complex systems. It's not, if you have one constituency to take care of, one can figure out how to do that. But in a city or a county, you have many different constituents, groups that are working for you, groups in different capacities are working, the different communities, the state, and the other contexts in which you're operating. And there's no common playbook right now. So context is essential to be able to understand the context in which you're operating, and then figure out what the resources are to carry out the needs that you have. We're playing a game of relative risk here. There is no, along with having no playbook, there's no way to make everybody safe. So what we're trying to do is figure out how do we ascertain the relative risk that our communities have right now, and then find ways to mitigate that risk based on certain conditions and requirements that we come up with. And we're going to have a few thoughts on how we go about doing that. But one of them is ethos, something that we've carried deeply and worked on a lot at SidePorch, is understanding what the underlying ethos and values are that drive an organization or a series of organizations, and use that as a foundational element to make decisions. So we think that starting with this position of ethos, as opposed to starting with trying to just come up with policies and practices, become really important. There's a bridge between one's values and principles and the practices and execution that come out that we've been trying to put in place for some of the groups we're working with, of a culture of health, saying, what do we stand for? What do we think health means in our context? And this isn't just physical or just physical and mental, but physical, mental, emotional, spiritual, occupational. There's a number of elements of health that as you look across that, particularly if you look in terms of the most vulnerable communities that you're trying to serve, we find that coming up with policies and practices and evaluating and changing over time become a little bit more straightforward. And that last piece, just to highlight it one more time, because it's going to come up in our conversation. We really do recommend that groups try to design their approaches for COVID and to deal with this pandemic with the most vulnerable communities in mind, because we find if you do that, chances are the less vulnerable communities are going to be taken care of pretty well. But vulnerability and vulnerable communities itself needs a conversation to figure out what you mean by that within your own local context. So on this call, I'm joined by some of my colleagues at SidePorch, Andy Reamer, Laureen Chandler, Dave Bioki, John Kobara on, and hopefully they'll jump in from time to time to ask some questions. But reach out to them if you have any questions in the chat. We're really grateful, as I mentioned, to be joined by two individuals that not only are they really good at what they do, they've impressed us as good human beings, which we think if you're going to partner with people, partnering with good human beings is a good place to start. Raman Bastani is the CEO and founder of Healthvana. Robin Smith, the CEO of Origin. Thanks, guys, for being here with us. We had a few other public officials that were going to join us in conversation. Turns out they're pretty busy at 9 a.m. Pacific on a Wednesday. I think Robin and Raman are as well, but we were able to convince them to join us. But a first question that I'm going to throw over to you guys. What are you doing during COVID? Can you describe the context in which you're operating? What are you doing? And how is it different from what you were doing before? So like, what were you doing last year versus now? But if you could start with times of COVID, just so we get that context in place. And Robin, maybe we'll throw it over to you and then over to Raman after.
Yeah, I'll kick off. So about a year ago, we were doing pretty much very similar things that we're doing here today for COVID. We are a diagnostics laboratory. We have a CLIA laboratory here in Boston, Massachusetts. And a year ago, we were cranking away on direct-to-consumer genomics and delivering information to patients. You probably heard a lot about some articles coming out around the death of the direct-to-consumer genomics industry around the holiday season. It's always a big season for ancestry products or ethnicity products, things like that. And we don't sell those types of products, but we focus on nutrition or health or fitness. And interestingly enough, February was the largest month in sales we've ever had. So we're accelerating through that sales ramp. And then, a pandemic hits. So as the FDA released guidance around emergency use authorizations for clinical diagnostic tests for COVID-19, we started validating a molecular assay here at our laboratory and received our EUA here on April 10th of this year. So since April 10th, we've been cranking out COVID tests. Our direct-to-consumer business is still moving along. So that's also fascinatingly, as the lockdown happened, people were staying at home, I guess, eating a lot of potato chips, and gyms are closed. So people are more interested in their health and well-being kind of because of this concentration. But we've really ramped up our COVID processing here. Just a quick note on capacity. We're at about 250,000 tests a month we can process through our facility. And I'm sure there'll be more discussion around what is the true lab capacity in the United States. And I think it's a fascinating discussion to have with the rest of the team.
Cool. Thanks, Robin. Raman, you also have been deeply connected in supporting the health of end users for a long time. But can you tell us about what you're doing in COVID and what you guys were doing before that brought you here?
Yeah, sure. Thanks for having me on. Our goal is to help end COVID-19. And so we've delivered north of 1 million patients their test results by working with municipalities, large ones, smaller ones, labs, universities, athletic teams. The goal is that we kind of help serve the last mile. So we make sure to capture that information from any lab, then end up sending it by text message or email to patients. So the whole goal is to help patients get access to their information on their mobile phones in a way they can easily understand and in a way that's actionable. So that's what we've been doing pretty well. Overwhelmingly, patients check their results by way of HealthVana by text or email within always a couple hours, but a lot of times within a few minutes. You can imagine the anxiety you have waiting for your COVID-19 results, right? Especially as we're seeing delays around the rest of the country. And so that segues in what we were doing before. We're used to dealing with anxiety-provoking healthcare data that's sensitive. So before this, our goal was to help end HIV, which we've done for the past 5 years. We delivered north of 15, 16 million labs to hundreds of thousands of patients around whether or not they had HIV, if they were already HIV positive, and all things that were related around your sexual health. So the most protected health information, and we'd been published in journals like the American Journal of Public Health and beyond, showing that we're good at getting better outcomes for patients when you involve them in their health on their mobile phones. And it ends up reducing a lot of the work on the healthcare provider side, in this case, the municipalities. So one of the municipalities that brought us on not too long ago, and we've been doing this work for about 3 months, but one of them that brought us on said, we're making 50 plus hours of phone calls a day just trying to reach out to people that are positive. Can you all help? And we said we could, and within a couple of days, they were at 0. So we're really good at the work we do. We're proud of it, and we're proud to be a part of a group of people that can actually help, including the work you're doing, Robin, and also the SidePorch team.
Cool. Thanks, Robin. So each of your organizations, along with an array of client types in different sectors, are working very closely with cities and municipalities around the country in a variety of settings. I was wondering if, in municipalities, as I said in the intro, they're trying to serve an array of stakeholders interacting in these complex networks. Can you talk about some of the most pressing challenges that you're seeing cities and counties face right now? What are the main challenges that are being faced? And how have these changed over the last few months? So maybe over to Robin, starting with you, because you're working with some really interesting projects around the country. So what are the challenges today and how are they changing?
Yeah, so it's interesting. We talk about this all the time in our laboratory. It's like we're seeing an entire new type of healthcare industry being built on the fly in the past, 8 weeks, right? And every day is like a year's worth of activity happening, both from just the inbound mayhem that you hear, and then the changing goalposts of what do actual cities need and how do they think about it. So today's challenges, probably if you asked me 12 hours ago, I would have said it was completely different, but I'll try to give you a couple really interesting people challenges that are here. And we were chatting about this earlier. When we're now doing, drive-up testing for COVID tests, or we're in congregate homes or nursing facilities, or at a summer camp or boarding school, or at a homeless shelter, that's a very, very different environment than a traditional diagnostic onboarding and patient provisioning and accessioning process. So the challenges that we're seeing are not around any kind of technological thing, because we partner with a lot of groups to do kind of the heavy lifting around some of the tech, and we have a heavy lifting in our lab tech that you'll see at some point. But the challenge is around human beings, right? And so in homeless shelters, and especially when we're dealing with migrant farm workers in a project we're working on in North Carolina, some of these individuals don't want to give you their personal information. And in that case, you still want to deliver a test, but it's very hard to actually deliver a test when you don't have a place to deliver it to, but they want to take the test. So it's an interesting discussion that goes on of how do we actually deliver the right information to this person in a way that they feel confident and secure about, but still abide by the state requirements that we have to report this to the state and local authorities for cases. So it's a challenge. So those kind of challenges are really interesting from a kind of a bottlenecking standpoint. And then the other thing that we also see a lot of is that organizations are going through, it's an RFP-like process where a state or a city, and we're talking to some cities that we've been talking to for about a month and a half and 2 months, they're like, we're gonna pick a vendor. So we're gonna go through a vendor selection process, like they're buying IT servers in a closet somewhere. And I'm thinking, man, you can't just pick one. You got to pick all of us, because if you think about the capacity, there's LabCorp, us, Quest, a lot of other really good medium-sized labs. There's academic centers that have good specialty services. Everybody put together, pouring 100% of activity and resource into this still isn't quite enough if we got everything onboarded. From just how do we stamp down the disease, right? So it's not a company A or company B or company C problem. It's a how does a municipality start mentally thinking about how do they pull together the big iron companies, the fast response companies, the medium-sized demand companies, and then the fast turnaround businesses and point of care. How do they blend that solution together for a continuum of needs that are going to happen in the community depending on where breakouts are happening and things like that. So it's a tough challenge, right? Nobody's ever had to do this before, and no cities.
So Robin, on that piece, like we've seen large counties in the United States in what usually took literally 13 to 15 months to make procurement decisions, making them in a week or two. So they're changing and working hard to change processes. How have you seen the individuals responding at the counties and cities to have to operate in this new type of decision-making environment? I mean, Bryce McDonald from UCLA talked about this last week in athletics and what he had learned in his military career coming through. But what are you seeing? What are you seeing of change?
Yeah, I mean, I think that's a really interesting question, because when we're dealing with individuals, everybody we're talking to, they understand the barriers, right? So every public official or somebody in charge of COVID testing or infectious disease response at the governmental level, they've all been excellent to deal with from let's get this going, right? And then we hit some weird, interesting bottlenecks like, I need data shoved into our data system this way, or there's something else going on with procurement, or there's some tangle up that's happening. But the individuals themselves, I mean, we've been on calls late night, it's like a 24-hour cycle for us. And I would even say the FDA during our EUA process, we were getting calls on our cell phones at 10:30 at night on Saturday from the FDA going, hey, we like this data. Can you go get more of this? And they were rapidly turning, as we were sending information, they were rapidly working hard. So I don't think it's, there's not this lack of effort for sure on the governmental agency side. It's more of there's traditional existing infrastructure challenges that happen from just getting things done. And nobody wants to do anything the wrong way too. So again, this is a regulated environment where you have certain requirements from a clinical lab like us. And so we have to be careful to make sure we're telling everybody this is exactly what we have to do too to perform. And it's interesting dynamics that happen. But from the individual standpoint, we're seeing these teams really rallying around this. I don't think we haven't run into anybody saying, no, we really don't want to do this. Maybe kind of on the micro level when you're down into a really, really small town somewhere, and they just haven't seen the outbreak yet. But from a state or large city or county levels, we've seen some pretty good response.
That's great to hear. And I'm going to throw it over to Raman, but something I didn't know that Tim McDonald was joining us from the RAND Corporation. He actually has a great research paper focused on the role of brokerage and intermediaries in complex systems that allow for this type of work to happen. Tim, if you want to throw that sucker up in the chat, I think people would really benefit from that article that I got to learn from last year. But over to you, Raman. What are you seeing as the big challenges today in the cities and counties, and how has that changed over the last couple of months?
Yeah, I think it's first important to note everyone we've worked with at a municipality level has been incredibly well-intentioned, hardworking, and fantastic to work with. Just like Robin was saying, sometimes there's just some procurement, whatever it may be, that just is generally a stumbling block. But we've had contracts go through in 2 days, which are also taxing on us, even as a startup. But I think the biggest challenges we're seeing is they're just trying to holistically understand how to serve their constituents. And that comes in a number of different forms. One is, number one, if you're doing testing, where can you get reliable testing? That's kind of the word we always use when we're evaluating different testing operations, meaning how quickly can those tests be turned around? How often are those going to have errors in them? For example, we see a lot of garbage in, garbage out with regards to data. So how is the data collected is it then distributed to the right person at the right time with the right information? When you're going this fast, there's always going to be challenges around those kinds of areas. Other challenges we see, I think the strategy initially for a lot of the municipalities we worked with was, we're going to bring a whole collection of labs, 5 or 6 or 7, all to jump in at the same time. But then what happened was 1 or 2 of them failed, and the whole system started to kind of have big issues. And it looked like testing was dysfunctional across the entire system when it may have been 1 or 2 of the labs. And so you see those kinds of network negative effects end up happening. So we've seen municipalities push more towards 1, maybe 2 reliable labs. And so that becomes useful when you have labs who do different types of testing. Some do the full end-to-end, where they'll show up at the nursing facility and work with folks. Some it's the massive drive-throughs. We work with Dodger Stadium that's doing close to 7,000-8,000 patients a day. And so there's different logistical challenges there. And like Robin was saying, we work with probably 200-300 different nursing homes, homeless facilities, different types of employers, rehab facilities. Those challenges are all different. They're not the same. What do you do when someone doesn't have contact information? Well, then you have to feed it to the medical director, who then is in charge of finding that person. So there's been a lot of different challenges. It isn't as simple as one person goes to a drive-through and gets the results back. We're seeing all sorts of different curveballs being thrown, and it's all in the effort of helping serve the different municipalities in a positive way. The other biggest challenge we're seeing is just contact tracing. First of all, if the results don't come back within 3 days, it's not as worthwhile. Second of all, how do you reach out to as many people that are positive, that are not willing to share their information because of things like medical mistrust? Sean, you spoke about communities of color being impacted. We've seen these exact same problems working within HIV for the last 5 or 6 years, where it's disproportionately folks that are of those communities that are affected. And so how does that play a role today in COVID-19? And how does that play a role in the future when you have a vaccination coming out? So what we're doing is trying to make this kind of solution where you have the PCR testing, the antibody testing, the flu shot, the flu testing, and the vaccination all come through Healthvana, so they can kind of have this solution for the next few months.
So Raman, you got through the history that you have of serving communities with really tough, scary results coming back to them. Based on what you've learned in your past work, how has your experience been? What are you learning about actually provisioning these answers back to communities? Because while we're thinking about the challenges facing the counties and the cities, and I agree, every person I have met that's working in cities and municipalities are operating from a real core of service position, and they care about giving these answers back. So what are you learning? How are people responding? What's necessary in order to serve those communities that are being tested?
Yeah, there's a lot of different pieces, Sean. The word that comes to mind is empathy. Understanding that the patients they're serving are terrified. The people that are coming to get screened are scared, that they need to get their results back quickly in a way that they can share with their employers. I don't know if this is the direction you were going with your question, Sean, in terms of what we're seeing.
Answer the question I should have asked, Raman, please.
I don't know if that's the case. So what we're seeing is generally you want to communicate with people. The only thing a patient genuinely cares about, whether it's a COVID-19 test, an HIV test, an oncology test, the only thing a patient actually cares about is, am I going to be okay? You have to answer that as soon as humanly possible and do it in a way that's empathetic, that helps them understand what that answer is, yes or no, and then what to do immediately next. Don't make them go through a bunch of hurdles. Don't make them talk to a number of people before you can get that. Don't make them wait on hold for 45 minutes to find out what the results are. You just have to help answer that initial question, and that helps build trust with the patient, which then you can say things like, hey, please screenshot this and notify people you've been close to. So our experience in working with the HIV community and things around that are that you just want to be direct, transparent, and make things real easy to use. Healthvana is at a 4th grade reading level. Health literacy is a real issue. And then access to information is also a real issue. So whether it's text or email, in the near future, we're figuring out how to reach patients no matter where they come from.
Cool. Thank you, Raman. Something that we've noticed over our time, the 5 years of SidePorch, but especially the last 5-6 months, that the character of groups and the ethos and the reason why people are working is very, very important in terms of performance, especially over time in these uncertain environments. when we've been asked to do evaluation across multiple resources, whether multiple testing labs or communication mechanisms, supply chain vendors, the first column we have in that evaluation criteria is ethos and values, which has struck a few people as strange, but it turns out over time that's important. It's something that we see from Origin, from Healthvana, and from some other groups that we can talk about as well. The ability to never lose sight of that end person, of what's important to her, is essential, but then the ability to break that out into the context in which that individual is situated. That ability to move is really important. So Robin, over to you. Like, you're working with a bunch of individuals that Raman just described, folks who are in vulnerable situations. Can you talk a little bit about the work that you're doing in North Carolina, in Eastern North Carolina? Because I think this really brings home a lot of the themes that Raman just presented for us.
Yeah, I will. And this is another example where state moved very quickly. So in North Carolina, they put out basically a bunch of feelers for laboratories to get involved. LabCorp is also one of our investors, but they're also headquartered in North Carolina. So here we come barreling into North Carolina saying we can help out on testing. And they put together a program called CHAMP. And there's a few organizations working collaboratively in CHAMP, and they divvied up some zip codes for North Carolina. We basically chose the hard cases because that's kind of how we thought about this. All full disclosure, my mother lives in Eastern North Carolina. My father was in the military and he retired there. So my mom's still in Goldsboro, North Carolina. It's a community where if you actually go there, it's amazing. It's one of these American communities that you see that it's not like you're living in Boston or San Francisco or New York City, right? It's an American town, and there's a lot of needs there. And so when we started bidding on this proposal to pick the types of zip codes we're looking at, we drew I-95 down the map and said, let's go east of 95 because it's where my mom lives. I know that area very well, and I also know from my experience when my father was diagnosed with lung cancer, people in Eastern North Carolina don't have access to the same quality care that people in a lot of other places in this country have. So we chose the hard case. And, we've been active now for about 3 weeks. North Carolina has also extended the program for an additional 3 weeks. It was funny because we were granted the zip codes on a Monday, and they said, you're going to start collecting on Thursday, right? And we're like, that's just a couple days from now. We're rushing kits down and getting this infrastructure set up. So it was a really kind of a fast stand up for us, and just a really interesting environment from both the mix of individuals down there. We're dealing with minority populations, indigenous cultures down in Eastern North Carolina as well, migrant farm workers. Just a little bit of kind of everything that's going on in a state like North Carolina. And again, the people challenges are interesting because entire families show up together for the test. And it's interesting to see how they go about registering themselves, and there's an educational process that we have to have for onboarding.
So Robin, in a theme that has been coming through that we haven't called out directly is trust, and trust of the individuals in the systems that are hopefully going to be there to serve them. You've shared a few stories about families or about even a religious congregation. Can you talk about how you're seeing those rhythms of trust be developed in pretty uncertain times right now?
Yeah. So as part of our program, we have to have a site for collections, and sometimes it's a town, or sometimes it's a church parking lot, a community center. And so 2 examples of that is one, a pastor passed away from COVID at a church, and the entire congregation showed up for one of our testing sites, which was just it's kind of heartwarming. It's also unexpected in some cases. In another small town, a prominent individual in the city had passed away, and at the funeral, they announced that, hey, there's this testing site, down the road, and the entire city pretty much, and it's a small town, right? But the entire city basically came and showed up. We were also in a couple other sites where, the local news crew shows up and shows us in the morning news, and next thing you know, the local police department's helping to manage traffic. A weird anecdote too, when the cars line up for drive-through sites, they somehow space themselves out about 6 feet apart too, which is also a wild human nature thing that you see, like even inside of the vehicles at a testing site, people are spacing their cars out, and then the traffic directors are trying to pack them back in for the lanes to get through the cycle. So part of the challenge is making sure that people know that these sites are there, and we're doing a kind of ramping up the outreach. And outreach isn't typical when you think about technology companies. You can't do this with like digital marketing. It's not really, advertising. You have to go and put physical flyers around at the churches and the community centers, and send word of mouth through some of these communities, because it's just a lot different from a kind of an activation standpoint than you would think about where there's mass media going on. So just a different kind of outreach that happens.
Thank you, Robin. So the next question is about, this challenge is not going away. I think we are going to be in an environment where we're grappling with this pandemic for quite some time. And we're interested for both Origin and Healthvana, operationally, how are you handling this growth of need over time? And maybe we'll start with Robin and then over to Healthvana. But Robin, you're hearing questions about lab capacity. We see it all the time. We were talking this morning before we got on about a CNN report last night saying there's no testing and we can't get, and it's wrong, right? There is capacity in the country if you know how to look. Can you talk about your capacity? And a little wrinkle here from a question that came in, other groups and industries. So we have someone that joined us that's working closely with the entertainment industry on content production. As capacity is seen to be limited, what is the availability of testing capacity? But also, how should we be thinking about other groups stealing that capacity from the counties and cities and healthcare? Can you talk a bit about that perspective as well?
Yeah. So our current lab capacity, we can do about 250,000 tests per month. And our turnaround times, we state are between 24 and 36 hours from when a sample arrives at our laboratory here in Boston. And we've been sticking to that throughout this month. We're only running at about a quarter of our capacity right now, which is surprising in a lot of ways. And again, we had this discussion earlier. Everybody's saying there's no testing capacity. We keep raising our hand and saying, send us some tests. We can process these things, and we're really good at this. So I think that's out there where we're just continually doing outreach to just reach out to folks and try to help. And following up on that, I think the wrinkles around like how do counties and local areas think about this. We're working with we get tests coming in even from MGH here locally in Boston, right? And I remember in the early days of this, MGH and folks being the way they are, they're like, no, we've got total control of this. We're good. And then sometimes people get overwhelmed, or there's supply constraints inside of these organizations, and they run out of reagents because the actual testing capacity isn't based on the number of instruments or the numbers of pipetters you have inside of the automation lab. It's actually based on your supply chain. And supply chain logistics, it sounds so boring, but supply chain logistics are critical to testing infrastructure. So
thanks.
A couple of days ago, I was walking some people through, and you guys as well, through our lab, and I was pointing out pallets that are in our facility. And this is all about palletizing the supply chain, making sure it's coming in and going out. And a lot of local smaller labs, they're really good at doing their testing, but they've never had the challenge of how do I get 6 pallets of pipette tips in to meet the capacity and demand? And that's a different challenge,
And thanks for that reminder, Robin. Andy's going to put a link in the chat right now to a virtual tour of Origin's lab to kind of see how a PCR lab works. Robin, I have been remiss in not pulling you into this conversation enough in the last few minutes. So can you talk about how you guys have managed to be able to scale to the demand that's coming your way and what you expect in the coming months?
Yeah, we have a really exceptional group of folks that all care about the work they do, given our background as a company. And so we've been able to add some additional folks to help us scale. Software is scalable. Fortunately, we don't need the pallets as much, Robin. But we're adding folks to help us kind of expand our efforts around the country. We've turned down a lot of work to go overseas. We want to focus domestically as much as possible, just because we know everything's local. From a scaling standpoint, we're adding people to the team. We're adding our own capacity is there to be able to do this work, which is good. We also want to be thoughtful with every municipality we work with. Everything is local, right? So when you hear about testing capacity on CNN or wherever it may be, it's going to matter what it's like to you and your neighborhood. Again, it's about, am I going to be okay, right? So as you're serving your constituents, what does it look like for you locally? And that can be a totally different version in one testing location you go to, for example, in Los Angeles, where we're based, or another location. One can have a 12-day turnaround, the other one can have a 36-hour turnaround. And so it really becomes local. And that's part of the challenge here, is not knowing where you're getting tested, what lab it's going to. And it's all pretty confusing, not only for the patient, but also for the people in the municipalities. And Sean, you asked about where we kind of see this going. I would say the big word that would be really helpful for everyone to know is insurance. This is going to shift from municipalities who are struggling with their tax base, with everything else that's happening with the pandemic. You're going to see them want to utilize insurance to make sure to pay for this. There's going to be a term, medically necessary is the phrase, which you're going to see come up a lot. So a lot of the labs are starting to shift. If they're not already doing billing, they'll start to do the billing where it'll be about $100 reimbursement. And you're just going to see a lot of the shift of the municipalities go towards that, whether it's in their drive-throughs and capturing insurance information, or whether this is going to start to shift more to employers in the future. Insurance is going to play a big role in this. And then someone's going to have to determine whether or not an attorney going into a law firm should be tested weekly versus, a healthcare worker. Where do you draw the lines on how often insurance is supposed to pay 100% of this with no copay? So I think that's going to be a huge part of this conversation, how often we get tested. And it's going to eventually be determined by the payers. There will be testing of last resort, which will be paid by FEMA, counties, states, et cetera. But I think you're going to see a large shift over to insurance, and the ability to make sure to collect on that is going to be one of the biggest challenges coming in a couple months.
Yeah, and I suspect this also will be a challenge to many of the vendors in the system that are going to have to learn how to work through insurance reimbursements, especially with small firms that are not set well up to wait on long net terms coming from those. Tim, you put a really good question that I think Raman started answering here, but would you mind asking your question and maybe even provide a few thoughts you have, because you work in healthcare sectors?
Yeah, thanks. And sorry, I don't have the video on. I'm in a low bandwidth area right now. Two different things I'd put in the chat. One question, just in general about budget planning for organizations and cities, both. I think just dealing with the uncertainty of how long the pandemic's going to last, and also how it will affect revenue streams. So whether it's earned revenue, donations, tax base, there's a few different dimensions to the uncertainty, and just sort of curious if you're getting a read on how folks are budgeting and how you, in your own work, you're budgeting. I've sort of noticed with universities and cities that I've been observing, they all kind of are just approaching it very differently, taking very conservative efforts, trying to cut expenses. And so that was one question. And on the issue with the testing is fascinating. I just assumed that there was not enough capacity. And so I wonder, I said in the comment, it seems to be a matching problem. Is it a matching problem? And the first thing I thought of was a couple websites that have popped up on trying to help people get PPE. Do you have PPE and do you need PPE? You go to the website, you click the button, and then trying to connect people. And I wonder if a similar effort is needed on testing. And it was some folks at MGH that developed that website, so you may be aware of it. But curious about your thoughts on both of those.
And maybe I can just chime in really quickly on the budgeting challenges. The kind of way we get paid for testing is probably as various as you could dream about. Different states, everybody and municipalities, they all have different budget pools and they're trying different things. Massachusetts has a program where Massachusetts state government is actually paying for the nursing home testing. They're one of the very first states to kind of roll out a comprehensive testing program. And we're fortunate enough to be able to help participate in that. One of the other programs we worked on in Boston City was testing the city employees. So we had a program going on there. And because we're a local hometown lab, we decided we were going to donate testing for the homeless shelters. So we did that out of our pocket. We just said, we're just going to test as many homeless shelters as you want. Just send them over to us. And that's kind of a social responsibility piece that we thought was very important for us to just take on and deal with. In the interim time between when those programs started and moving along, we also, as Raman was mentioning, we got our medical P10 ID now, so we can go after reimbursement billing as well. And so that's in place for our organization. And now we've been rolling out testing with no out-of-pocket costs for a variety of different groups and organizations. In North Carolina, it's state-sponsored to some extent, but then it's also Medicaid and Medicare reimbursement for us. So it's a combination of us working with the state to first see if there's federal reimbursement, and then there's some administrative fees that we can tap into if we have challenges. There's also really great organizations that are trying to help from a community standpoint. So there's this group called Dogwood in Western North Carolina, and they have an investment firm and kind of a charitable outreach. They're basically paying for Western North Carolina testing to happen just out of their pocket. And, we're the lab that is helping them. And so, we work together and collaboratively on figuring out what's the cost basis for us to do testing for this community out there, and work together on that. So it's like a cobbled together community in some cases, but just really fascinating work.
Tim, good questions. I guess we've done quite a bit of testing across the country now, and I would say it's going to go back to the same things I mentioned earlier. Local, it's just going to depend on where you are. Is the state providing money to the county, and is the county then kicking it down to the different cities? Does that city have its own health department? It really does vary of how they're getting reimbursed, or if they're trying to get reimbursed through FEMA. But it's going to come down to insurance, I believe, more than anything else. The ability to capture insurance will be a big piece of this, and you're going to start to see more established players come in, I think, that are used to doing different types of work in certain communities. So that's the first part of your question, Tim. I'm trying to remember, what was the second question, Tim?
I think it was kind of tied in just matching. And as you're talking here, I'm thinking, as you're talking, I'm thinking there's the matching, but the matching seems to be needing to occur because it's such a fragmented process period.
Sure.
Yeah.
Yeah, I think it's incredibly difficult to do. Testing capacity can change from one lab overnight. So the idea of matching and having real-time wait times, I think it's going to help. It's not going to help, actually, generally. You can do it, again, local. It's got to be locally driven by the municipality, if it's in that case, or if it's by a university, if it's by a lab that's local doing a lot of the great work that Robin was mentioning and contributing free testing and such. But I think it's going to be really challenging to do that. It's not the PPE challenge in the same way where you can source masks from here or there. This is going to change on a daily basis depending on what lab has capacity or what's happening. We've seen examples where one lab we work with gets a huge order of, let's say, 30,000 tests in a day they weren't expecting. What happens to the rest of those tests, right? So it's really hard to be able to give a sense of that. So everyone, it's just trying to figure out what's happening in real time. And a lot of times people look on Twitter, or they reach out to us on Twitter to understand what wait times are.
Yeah, and the contextualization, because each of the labs offers slightly or significantly different offerings and connections and expertise, that figuring out how to build a system that can take into account the contextualization required to make those matching, which makes for a really nice transition, I think, over to Dele, who has been working on these problems throughout his entire career. But Dele, would you want to throw your question out? Because I think it's pretty important for the conversation we're having.
Yeah, hi everyone. So again, sorry, my Wi-Fi is a bit shaky, so I'll just stay off video. But what I wanted to know is, in light of all the concerns that are being raised around communities being reluctant to share personal information and the like, how are you guys facilitating or enabling anonymous testing?
Let me jump in on that one. Since I've worked in HIV before, where anonymous testing, they actually call it confidential testing because they want to be able to track back to who it is in case someone is positive. I don't think we've seen any anonymous testing. And we work at the direction of the covered entity, which is the municipality in most cases, or the university or the lab. So they're going to want to know who's actually getting tested. And it becomes even more important as you are trying to bill insurance. If people are either undocumented or, let's say, don't have insurance for either circumstance, there is going to be some testing available, but we haven't seen much of that thus far. And we've processed well over 1 million test results for patients thus far.
Yeah, I mean, just to chime in on that again, it's a big issue. So I do a lot of work around privacy and data management, and we're part of a group that have been working with Senator Thomas's office in the state of New York to put forward a COVID bill. And there's a huge concern around contact tracing. There's huge concerns of this data being used by law enforcement, by ICE, for all of these issues. And obviously this is going to become a huge barrier in many regards. So I appreciate that there's nothing really being done about that at the moment. Are there provisions in place, or is it something that you're thinking about or approaching?
We're doing some work on, sorry, Robin, we're doing some work on digital contact tracing that'll be coming out in the next couple of weeks in a way where you're able to anonymously notify additional people. So absolutely, and I read the article in the New York Times about contact tracing today in New York, for example. It's just not working as well. And because of where we sit in the chain, we're delivering those results. And we're notifying people if they're positive or negative at that moment. And there can be an opportunity that has this, share, save lives, anonymously share with 1 or 2 people you've been around, before and after you're symptomatic. So that can go to someone else. But it's a real issue what you're discussing. And I think every municipality is going to have a different way of thinking about it. And it is coming, there's no doubt. There's lots of things in Congress that are being batted around. We're watching them carefully, but it's hard to know where they're going to shift.
Yeah, well, one of the things I think is really important that that we can chime in from a laboratory perspective, the Clinical Laboratory Improvements Act that was enacted, I think, in the mid to late 80s now, it regulates from the CMS, it regulates CLIA laboratories like us. And I am a firm believer that technologically, we should just take a scrambled barcode and a hash ID and then send that back to the source that sent it to us, right? Technologically, we could totally do fully anonymized testing for individuals. However, federal guidelines and regulatory guidelines prohibit us from doing that as a laboratory. So I am a big proponent. I would be glad to lock arms with whoever wants to march in and do battle to rev the CLIA Act once for modern days, because the world in 1980, mid-80s, was very different technologically and socially than it is today. And I think there's ways to make the second set of improvements, which is to harden that a little bit from a quality and reproducibility and lab continuity and reporting standpoint, but also open up some things around privacy and patient protections that I think would be really important in there. That has to be done sooner or later. This COVID crisis, I think you're another flashlight that's shining another piece of healthcare that's messed up right now, and we just haven't got around to that culturally and as a country. I think it needs to be done for sure.
So we have about 5 more minutes for questions before we're going to wrap, because both of these gentlemen have meetings that they're running into after giving us a generous hour of their time. So any more questions from the audience? Dave, you threw something into the chat.
Oh yeah, it was more of a big picture question. Clearly, our guests here are much more connected to testing than I, and I recognize it's a little bit a broader scope from what we're talking about today. But what's your sense on just what are we going to need for testing as a country over the coming before this whole thing is done? I mean, is it a matching problem, as Tim suggests right now? There's plenty of capacity. We just have to solve the matching problem, or will we genuinely need more capacity. I'd just be curious to get your guys' take on that. What's the future of this?
Well, I'll just try to do this really quickly. I think that the challenge in testing isn't necessarily the total capacity in the country, it's the capacity, utilization, and focus. If we treated this as almost like more, I hate to put it in these terms, but more like a military campaign where, okay, there's real breakout issues happening in southern states and a few key areas, why not focus all the attention in kind of like a sweeping wave across, the country uniformly, with every organization coordinated and working together? This is going to require massive high-level coordination among all of the labs like us and governmental agencies, right? But I think centralized coordination around a true nationwide testing campaign means you don't have to create 300 million tests a day. What you need to do is focus the 5 million tests we have a day across the board in a systematic manner, instead of 100 tests being doled out to different cities around the country. Really focus so that you can get snapshots done and kind of a cleaning sweep moving through the country. I think that approach would be a really interesting thing to think about. How do we get that through? But it's a tough challenge. It requires some motivation from a centralized source, and maybe it's a collection of private groups that get together and form a collective to say, this is what we're going to do. Get LabCorp and Quest online because they've got the big iron, and 20 labs together and go do this. I think that collective collaborative effort could help save the day.
Yeah. And I just put a link that I meant to mention earlier. A colleague of ours, Sean Richards, who's involved at ASU, sent this over of an effort that university, which like so many things ASU is doing to try and be innovative and build a future that we want to be part of. This is something worth looking at. Raman.
Short answer, more. I don't know what that looks like. And then I differ a little bit with Robin on the testing capacity part. There's certainly great organizations like his that have some capacity, other areas you don't. And I'm going to go back to local. If you can fly it in, great. If you can't, it's a lot of work, and you have different incredible folks that are, we've worked with in the fire departments that are setting these things up, emergency medical services, public health folks. This is a different beast to be tackling. And so I would just continue to say local would be helpful. And local can mean 4 or 5 states near you, but figuring out what that means locally, and maybe that goes to the matching question of just who's even out there. And I think folks like SidePorch are doing a good job of kind of illuminating what that looks like. We're lab agnostic, so we work with a lot of labs. So we hear from labs probably 20 or 30 a week who will mention the things like, hey, we got some capacity. And the question is, how much capacity? Because if you get an order that's triple your capacity, all of a sudden you're backlogged. And then what happens? You may not have those pallets in the back like Robin does. So it really is local, and it's changing all the time, which makes this really challenging. And we've talked to folks at HHS, we've talked to state leaders, we've talked to a lot of different people. There is no uniform answer. And so I think what you're seeing is people focusing really locally to take care of their populations as much as possible.
Yeah, and the next question that we don't have time to get into is, that's a local and national context, and how does our particular context in the United States need to interact with the global context that this pandemic is forcing us to look at, or at least encouraging us to look at, which might be a topic for another session. Thank you, Robin. Thank you, Raman, for sharing some of your time and wisdom. To go back to a few of the things that we've learned at SidePorch over the last few months and the last couple of years, in particular, in an environment where we are all on Zoom calls all the time, we don't have an opportunity to spend time face to face with people. I feel like I know Raman and Robin very well right now, but we've never been closer than the rooms we're sitting in any conversation, which means trust is needing to be established in different ways in these environments, which certain communities have learned from. So under pressure and in these type of information settings, trust needs to be established differently. And so we're trying to figure that out. And we do believe that trying to get a sense of values and ethos and what do you stand for and how do you operate becomes a really important thing to get on the table right away and continue talking about and working through over time. Because as we're seeing, when people are under pressure, they operate differently. And we're fortunate here in this session to be with 2 individuals who are really coming through elegantly and gracefully in times of pressure. So Robin, thank you very much. We are going to be sharing this out. This video will be available later today. We'll reach out to everyone on this call to see if there's anything that we can do to be of service. We're happy to connect you to Robin and Raman or anyone else that would fit your local context. But really thank you to everyone on this call, because I think every single person that joined this call is really trying to operate in service to the communities that they're operating in. So with that, I'll close it off. The SidePorch team will stick around for a little while if anyone has questions or wants to continue the conversation. And we wish you guys a safe and healthy day and rest of the week. Thanks for joining us.